We could just give them a couple of minutes, Chaturbush, before we start.
Yes.
Sir, we are live on YouTube, so we are visible and audible.
Yeah, but we could just wait for a couple of minutes.
Yeah, ma'am.
Smita, can you promote Dr. Jayanti Mani as panelist? I think she has joined through the link.
Professor Marson, is that a convenient time for you? What time is it at your end?
Yeah, it's very convenient. It's 3:30 in the afternoon.
Okay. Okay. So that's good. It's when we connect with colleagues in the United States that, you know, they end up having to do it at a very unearthly hour.
Yeah. Yeah. No, it's fine for me.
So we are waiting for maybe one more minute to let the attendees join. Then we'll start.
It's my office is being decorated, so I've had to come home to have to give the presentation because.
Okay. Okay. Decorated sounds really fancy. Okay.
Well, having a new floor, having the
Okay.
carpet.
Okay.
So I think we'll gradually start.
Yeah, maybe we can. It's 8:02, right?
So very good evening and welcome to the second session of our epilepsy course. And on behalf of Indian Academy of Neurology and its epilepsy subsection and its chairperson, Dr. Mamta, I welcome you for all this second session of this epilepsy course. So we have discussed about the initial epilepsy classification and seizure classification. And now today we move on to the epilepsy medical management. So we know that there are more than 25 anti-seizure medicines are available, and it is a Herculean task to choose the appropriate medicine for the patient. And I think this task has been hugely simplified by the landmark 2 SANAD trials, and the lead investigator and the principal investigator of that trial, Professor Anthony Marson, is with us today to solve or help us in solving the puzzle of choosing the initial monotherapy for the epilepsy. I think all the people who are working in the field of neurology and epilepsy are aware of the SANA trials and Professor Anthony Marson. And if we can name the one person who has really changed the practice of the epilepsy at a greater extent across the world, I think Professor Anthony Marson is one of them. He's a consultant neurologist and epileptologist at Walton Center and a professor at University of Liverpool, one of the senior most and the renowned epileptologists in the world. And he's leading and the chair of multiple national epilepsy programs in the United Kingdom, and which forms the policy in the epilepsy management. And he's a Secretary General of the European Academy of Neurology and coordinating editor of the Cochrane Epilepsy Group. And all of us must have read many Cochrane reviews authored by the Professor Marson. And importantly, he's the lead investigator in the SANAD and the MES trial, which all of us are aware of that. And his research has actually led to the formulation of the important policy, service, and treatment decisions worldwide. So we are really privileged to have Professor Anthony Marson with us. And thank you, sir, for accepting our invitation. And we welcome you on behalf of Indian Academy of Neurology. And these are we will be discussing. So, you know, the SANAD trials, which has really changed the practice of epilepsy across the world. Along with us, we have two eminent Indian panelists, Professor Gagandeep Singh, senior neurologist and epileptologist in the country, who has been the past president of Indian Academy of Neurology. And I think every one of us aware of Gagandeep sir's contribution to the epilepsy and neurology in India. And second panelist is senior epileptologist, Dr. Jayanti Mani, who is working in the field of epilepsy for last 20 years and a prominent epileptologist and neurologist in the country. So we welcome you both. And with this brief introduction, we again welcome Professor Marson and request him to start his talk on initial monotherapy of epilepsy.
And thank you very much for the very kind introduction. And it's a real pleasure to join you. And of course, it's much simpler by Zoom. And I really hope that we'll have a fun meeting. Of course, I do really enjoy visiting India in person as well. My first visit to India was back in the 1980s, and I've been back lots of times. And I really do enjoy interacting with my colleagues from India. So I am just going to spend the next few seconds just trying to make sure that I share my screen properly. Just bear with me a second. And hopefully that's in presenter view.
Yes, sir.
Yeah, excellent. Okay, right. So I have been asked to talk about two really basic things in some respects, but of course epilepsy is heterogeneous and complicated, so there's never a simple answer even to a simple question. But the questions are about when we should start treatment and what we should start treatment with. And I'm going to unashamedly focus on randomized controlled trials that we've led from Liverpool in the UK. And of course they are data which have been collected mainly in the UK, and we need to think about how well they reflect practice in other parts of the world. And I'll be really very interested to hear your views as to how well these data inform and reflect practice in India. And of course, I've had the opportunity to visit India quite a few times, but I've never really had the opportunity to practice medicine or neurology in India. So the first, what might seem to be a simple question is when should we start treatment with an anti-epileptic or an anti-seizure medication? And we could be quite reductionist about this and say, well, should we start treatment after a first seizure? Should we start it after a second seizure? What about 3 or more seizures? But of course, it's not simple as that, because seizures happen over varying time frames. So what if seizures have happened over significant time periods? Somebody that's had 3 seizures within the past 3 months is very different to somebody that's had 3 seizures in the past 20 years. So it's not just about the numbers; it's about the density of the seizures as well. And also, what if the seizures are of relatively minor symptomatology? Somebody having myoclonic seizures or focal aware seizures might be less interested in starting treatment than somebody that's had a convulsive or a tonic-clonic seizure. So these are things that clearly we need to take into consideration. And what we're really thinking about is a risk-benefit scenario. What's the benefit of starting treatment, and what are the risks associated with starting treatment? And clearly, the main benefit that we're looking for is to reduce the risk of further seizures. And in the longer term, we want people to enter a long-term remission from seizures and get them functioning, get them back into education, get them back into employment, and maximize their opportunities. And we want really good long-term outcomes. Of course, starting treatment comes with some risks, and the main risks are really adverse effects from starting anti-seizure medication. And we need a way of balancing those risks. And one way to do that is to think about the quality of life of people, measuring the quality of life consequences of either starting or not starting treatment with anti-seizure medication. And I think we'd probably, most of us agree, if somebody's had 3 convulsive seizures in the past 3 months, the benefits probably outweigh the risks, and we would recommend starting treatment. But what about somebody that's had 1 seizure? Or what about somebody that's had 2 seizures, but they're 10 years apart? That's a much more difficult risk-benefit situation to consider. If we just think about first seizures, there have been a number of systematic reviews. This is quite an old systematic review, and I'm aware there's some updated work, but this slide shows quite a simple picture, really, trying to estimate the risk of a recurrence after a first unprovoked seizure. And this is the first big meta-analysis that was done in this space by Anberg and Shlomo Schinner. And on average, we know that nearly 50% of people will have a recurrence after their first seizure. And that risk is higher if people have got an abnormal EEG and their seizure is symptomatic. So if somebody's had a brain injury and they've got an abnormal EEG, then their risk of a seizure recurrence is greater. But one of the challenges is that if we want to make a treatment decision, we need randomized controlled trial data, not only observational study data, because we need to understand, well, what's the difference if we start treatment or if we don't start treatment? So we need not only observational data, which tells us about overall risk, we want to know, well, does treatment modify that risk? And if so, how much does it modify that risk? And if we move on to people that have had a second seizure, this hasn't actually been examined very well. And again, some of the better data comes from observational data comes from this, again, rather old New England Journal of Medicine study, which highlights that the risk of having a third seizure after a second is more than 80% for the majority of people. And these are the data which really inform our current policy of starting treatment after a second seizure. We assume that if somebody's had 2 seizures, their risk of a third seizure is very high. Therefore, we start treatment on the assumption that starting treatment has a significant impact on people's risk of having another seizure. We don't actually know whether that's true, although it probably is true, but we don't know the size of the impact. And partly because we don't really know the natural history of untreated epilepsy, because many people enter spontaneous remission. So we need to be careful that we don't overestimate the effect of treatment. So one of the ways that we tried to address some of these questions quite a long time ago now, of course, was in the MESS trial. This was the multi-center study of early epilepsy and single seizures. And here we're trying to answer the question, is it beneficial to start treatment or delay treatment for people either with first seizures or people that have had more seizures, but there's uncertainty as to whether treatment should be started. So this was a randomized controlled trial that recruited people from Europe. So just over half were from the UK, and then the rest were from mainly from other European countries. Nearly 1,500 patients randomized to either start treatment straight away or delay treatment where treatment can be started at a later time point. So this is a sort of trial which is assessing the policy. We've got these patients where we don't know whether we should start treatment. Our policies are either start treatment straight away or to delay treatment. And I'll talk more about policy, trials assessing policy when I come on to the SANA trials later on. And clearly, if we're seeing people with first seizures, one of the things we're really interested in is, well, what's the seizure recurrence rate? And the slide here shows graphs for time to a seizure recurrence. And there are two graphs. The one on the left is for patients that had only one seizure at the start of the study. And the graph on the right is for people that had 2 or more seizures before entering the study. And we see that if for people that have had a single seizure, they've got a higher risk of seizure recurrence if they delay treatment and a lower risk of seizure recurrence if they start treatment. But what you can see is actually the difference between the two curves is fairly small, isn't it? And so the treatment effect is relatively small. And at 2 years, it's about 10%. So we can convert that into a number needed to treat. So that means that we need to treat 10 people. So a difference of 10% equates to a number needed to treat of 10. So we need to treat 10 people to prevent 1 recurrence. So to prevent one person having a recurrence over 2 years. So that tells us straight away that if we're thinking about starting treatment in people with first seizures, we're actually going to have to treat a lot of people to derive benefit, and we're therefore potentially exposing a lot of people to treatment and potential side effects. And I think this is really important to consider, and I'll highlight this again later when we start to think about the new definition of epilepsy, which I think is resulting in people with first seizures being treated when that might not actually be required. If we move to our group with 2 or more seizures, and remember these are a selected group of people where there was uncertainty. So these are mainly people that are having seizures that were minor symptomatology or seizures that were spaced out in time, whereby the clinician and the patient were uncertain. So quite a heterogeneous and mixed group. But the difference between the curves here is greater. But a 20% still equates to a number needed to treat of 5. So we need 5 to treat 5 people to prevent one seizure recurrence. Okay, so treatment reduces the risk, but it doesn't reduce the risk actually by as much as we might anticipate. And of course, we're also interested in longer term outcomes. And the outcome that we looked at in this trial was whether people achieved a 2-year remission from their seizures. And what you can see from this curve, which is looking at time to achieve a remission from seizures, people starting treatment achieved a remission sooner, but the lines are very close together, aren't they? And a few years down the line, they're superimposed. So this is telling us that for people with first seizures, if we start treatment, we reduce their risk of seizure recurrence by a small amount, about 10%, but we have absolutely no impact on their longer-term remission rates. And there had, at the time this trial was done, there was concern that if we didn't start treatment straight away, people would have more seizures, that would cause damage to the brain, and that would reduce their chance of remission. And that is clearly not the case. So we can't use that as an argument for starting treatment early on. And for our group with 2 seizures, we see a similar story, but the effect is slightly larger, and it takes longer for the remission to occur. If we look at quality of life, we don't see any overall difference in quality of life as to whether we start or don't start treatment. And that's because there's balance. We improve quality of life by reducing seizures, but we also reduce quality of life by giving people the stigma that they feel they've got epilepsy by starting anti-seizure medication and by causing side effects. So there is no quality of life advantage from starting treatment early for people, particularly people with first seizures. So I think bottom line take home message here, which you probably know already, that for people with single seizures and early epilepsy, early treatment has no impact on longer term outcome, and treatment decisions, I think, should be based largely on interpretations of risk of early recurrence. We can do prognostic modeling. I'm not going to go into this in any detail. We can very broadly use the data from the MESS study to broadly stratify patients into 3 groups: a low risk, a medium group, and a high risk group based on characteristics of the individuals. And even if we focus on the high risk group, so if we focus on the 3-year recurrence risk, we can stratify people into the high risk group, and they would have about nearly a 70% risk, so 6-7% risk if they delay treatment, and a 46% risk, nearly a 50% risk if they start treatment. Again, highlighting that the relatively small treatment effect, but it might be these people in the higher risk group that might be more willing to start treatment. And of course, I think you had Bob Fisher to a previous meeting, and it was Bob led the group that put forward the newer practical definition of epilepsy, which comes with some problems, I think, for us to just take into account and make sure that we don't jump to conclusions and go to groupthink. So our definition of epilepsy has effectively 3 parts to it. The first is 2 unprovoked seizures at least 24 hours apart, and that maps our current long-standing working definition of epilepsy, and that's based on what's happened. So that's easy. We're sure seizures have happened. We can give somebody a diagnosis of epilepsy. We also have a second definition, which is 1 provoked seizure and a high probability of a recurrence over the next 10 years. And that's a definition based on what might happen. And that's problematic because we can't reliably individualize prediction. We can broadly stratify, as I showed you early on, and telling people they're in a medium, low or high risk group is one thing, but stratifying them and tell them whether they have or they haven't got epilepsy is quite a different thing. And it is really very difficult to confidently tell whether somebody's risk of having another seizure is 60% or more. So there's a real risk here that we tell people they've got epilepsy when they haven't, and that we tell people they haven't got epilepsy when they have. And there's also a real risk of groupthink in that we say, well, we're giving people a diagnosis of epilepsy, therefore we should start them anti-seizure medication. And there's a risk that we start a lot of people anti-seizure medication unnecessarily. So we need to be really careful about this part of the definition. And of course, the third part is around whether we can give somebody an epilepsy syndrome diagnosis. So just a word of caution there. So how do we deal with this practically? And this almost certainly reflects how you're practicing already. I would suggest that we start treatments by and large if people have had two or more seizures, which are of significant symptomatology. They've occurred over a period of less than 6 to 12 months, and the consents of the patient's happy to start treatment. And this is very much a broad consensus view, but the risk-benefit ratio hasn't been assessed in randomized controlled trials. We should start treatment following a single seizure if the patient's in a high-risk group and the patient wants to start treatment. And it's really important that we don't recommend starting treatment for patients without having that conversation about uncertainty and the likely signs of benefit. And we might want to start treatment for patients with minor symptomatology or long periods between seizures if the patient's again in the higher risk group and the patient wants to start treatment. And of course, my experience, people that have dislocated their shoulders or suffered significant injury in their early seizures, very interested in thinking about starting treatment. So I want to go now on to the next part of the question that was posed about which anti-seizure medications should we start. And of course, as was mentioned during the introduction, we have many anti-seizure medications available, and there are more coming through the pipeline. we've got a really important question about which drugs should be used first line, because we want to be using medicines that are effective, safe, and also are cost effective. We don't want to be using a lot of expensive treatments if we have cheaper treatments which are just as good as our other treatments. And what are we aiming for? It's not rocket science, is it? We're aiming for good seizure control. We're aiming for no or minimal adverse effects. And ultimately, we want to get people back to their normal life. We want to get them into education, into employment, and so on. So we want to maximize their quality of life. And we want to be spending money, health service resource, and people's resources wisely. So we shouldn't be recommending expensive treatments unless there's really good evidence that that's what we should be doing. What we really need to answer these questions is what we can call pragmatic trials. And if you do a Medline search for clinical trials in epilepsy, most of the trials that have been conducted are trials sponsored by industry and where the intent is to get a drug license. And they're mainly trials in refractory epilepsy. And whilst those trials get a drug licensed, and we might call those explanatory trials, those drugs they might get a drug license, but they often do very little to inform our everyday clinical decision making. So we've got this real paradox in epilepsy where we might have a lot of trials in an area like refractory focal epilepsy, but we don't have the evidence that we need to inform our clinical decision making. And the place where we've undertaken the most pragmatic trials is early on in the patient journey, trying to assess which treatments we should be using as a first line treatment. And these sorts of trials, pragmatic trials, will try and measure both clinical and cost effectiveness, and they'll try and reflect everyday clinical practice. And to do that, they need to be run in everyday settings, in routine clinics, and they need to have very few inclusion and exclusion criteria, so that we're recruiting a population of patients which represent the people that we're seeing every day in clinical practice. And these sorts of trials need to measure long-term outcomes. And of course, that's an expensive thing to do, and might be prohibitively expensive for industry, given the way they organize and run their trials. But if we have a condition like epilepsy, which can be lifelong and have long-term impacts, we need to measure long-term outcomes, such as whether people are entering a long period of remission, such as 12 months free from seizures. And the whole aim here is to inform public policy. We're not interested in informing regulatory decisions about whether a drug gets licensed. We want to inform policy, the guidelines that NICE produce, that your academy and many other academies around the world are producing. That's the target audience here. Can we inform how we're treating epilepsy in the clinic around the world? So I'm going to dip into the area of newly diagnosed focal epilepsy, and I'm going to focus initially on the SANAD trials, which have been highlighted to you so far. So in the first SANAD trial, which was commissioned by the National Health Service in the UK, we had carbamazepine at that time as a first-line treatment for focal epilepsy, and we needed to know whether some of the newer treatments that have become available were effective first-line treatments, particularly as some of them have been granted license for use in monotherapy. So we compared carbamazepine with gabapentin, lamotrigine, and topiramate. So the slide here is for time to achieve a 12-month remission from epilepsy. So hopefully you're familiar with looking at these sorts of graphs. So we've got time in years across the x-axis, and across the y-axis, we've got the proportion of people achieving a remission from seizures over time. And we've got a black line for carbamazepine, blue is topiramate, green is lamotrigine, and red is gabapentin. And a bit like the MES study, you might say, well, actually, those lines are fairly close together. But what we find here is that carbamazepine and lamotrigine are better, significantly better than the other two treatments. And lamotrigine and carbamazepine are very similar. And our interpretation of the data when we first published this was of non-inferiority. So there wasn't an important difference between carbamazepine and lamotrigine in the longer term. What's really important to understand is these data are, or this graph shows an intention to treat analysis. So an intention to treat analysis assesses policy. So the question here is, what happens if we start carbamazepine, gabapentin, lamotrigine, or topiramate first, and then follow people up? And whilst we're following people up, of course, doses and drugs will be changed. So carbamazepine might be swapped to an alternative, lamotrigine might be swapped to an alternative. But the policy here is, what happens if we start one drug or another? And which explains partly why we don't see big differences between drugs, because of course the clinicians in the background are seeing patients in the clinic and doing their best to get seizures under control, increasing doses and changing drugs. So the policy here, the comparisons of policy is that it's better to start carbamazepine or lamotrigine than topiramate or gabapentin. The next primary outcome that we looked at was one of time to treatment failure. So the graph here shows the proportion of people that are staying on the treatment that they were randomized to. Of course, people are staying on lamotrigine, which is the green line, more than they're staying on the other treatments. And it was broadly these data taken into consideration that led to lamotrigine being recommended as a first-line treatment. And there was a bit of resistance to that because, of course, people in the UK and other places were very familiar with prescribing carbamazepine as a first-line treatment. But over the years, lamotrigine has really taken over as a first-line treatment for focal epilepsy in the UK and in many other countries. Excuse me. So more recently, we have undertaken the SANA-2 trials. And the primary question here was whether levetiracetam or zonisamide should become first-line treatments, accepting that lamotrigine has now become the first-line treatment in the UK. And of course, we were very interested in levetiracetam because that had become very, very, very widely prescribed, despite real lack of evidence to justify the very widespread use of levetiracetam that was starting to come into place in the UK and in many other countries. So the graphs here again are for time to 12-month remission. We've got days along the x-axis this time instead of years. And again, we designed this trial for non-inferiority. The first thing to highlight again is this is an intention to treat analysis. So it's comparing the policy, and in the background, clinicians are changing dose and drug to get the patients under best control as possible. And we see that overall, lamotrigine just about comes out best, with zonisamide appearing to come very close second, if not very similar, and the levetiracetam coming behind. And we had a non-inferiority limit of here. I haven't included slides to explain non-inferiority in detail, but levetiracetam didn't meet our definition of non-inferiority, so there are likely important differences even from a policy perspective about levetiracetam compared to lamotrigine. When we compare zonisamide to lamotrigine, we get an indication that there might be non-inferiority. But we also need to take the per protocol analysis into account. And what the per protocol analysis does is it looks at the proportion of people that achieve a remission on the drug that they were randomized to. And here we see a very different picture. We see that patients are much more likely to achieve a remission on lamotrigine than they are on levetiracetam or zonisamide. So in the previous graph, the reason the lines are so close together is that drugs were being changed. So people were being taken off zonisamide and taken off levetiracetam because it either wasn't controlling their seizures or it was causing side effects. And we see quite big differences here between the treatments. And if we then move on to treatment failure, and in this part of the presentation, I've split treatment failure up into two types. So on the left-hand side here, we've got treatment failure because of side effects, adverse events. And over here, we've got treatment failure due to inadequate seizure control. And what we can see is that treatment failures are much more likely because of adverse effects. Zonisamide got a quite high treatment failure rate because of adverse effects, followed by levetiracetam with lamotrigine with the lowest failure for adverse effects. And there were smaller differences in terms of inadequate seizure control. So I think it's really important to reflect here, because I think we were of the opinion that levetiracetam is a safe treatment that doesn't cause side effects. But of course, if we're looking for sodium channel type of side effects, we're looking in the wrong place. So when we drill down to the adverse effects, what we see is much more in the way of psychiatric sort of mood disturbance, agitation, with levetiracetam and zonisamide resulting in failure of those two treatments. When we look at cost effectiveness, we find a very stark difference between the drugs. And of course, this is very much from a UK perspective, and the picture could be very different in India. So the graph here shows what we call cost effectiveness acceptability curves. What they're trying to do is plot the cost effectiveness of a drug at different thresholds of willingness to pay. And in the UK, we're typically willing to pay for a drug if it costs £20,000 for a quality adjusted life year, and we might be willing to pay £30,000 for a quality adjusted life year. But the bottom line is that zonisamide and levetiracetam were more expensive than lamotrigine, and they produced worse quality of life. So, which is why we end up with almost a flat line. No matter what you're willing to pay, lamotrigine is cost effective, and no matter what you're going to pay, levetiracetam and zonisamide are not going to be cost effective first line treatments in the UK, telling us that we should be using, highlighting that we should be using lamotrigine in preference to other treatments potentially. Of course, what we also need to do is to take all of the evidence in the round and try and look at this within the context of a meta-analysis and a systematic review. So one of the things that we've been doing over the past 20 years is accumulating data and doing regular updates of our network meta-analysis of our individual participant data meta-analyses of anti-epileptic or anti-seizure medication trials. So what we've done here is we've done our best to get hold of the original trial data. So on the left-hand side here, it shows you what the network looks like. So the blue dots indicate the amount of information we've got about a specific drug, and the black lines indicate the amount of information that we've got about a comparison between two drugs. And in total, there are 89 monotherapy trials with just over 22,000 participants in them. And we've been able to get the original trial data to reanalyze that and contribute to a network meta-analysis from 39 of those trials from nearly 15,000 participants. So we haven't got the whole 22,000, but I'd suggest that this has been a Herculean effort. This has been a massive effort to work with the trialists and acquire the data and analyze it. And of course, some of the trials are really quite old, and the data are no longer available. So I think we've done a pretty good job, although I say so myself, of getting the data to try and get an overview of the data. So the plots here are for time to treatment failure, and I'm just going to focus on the left-hand side of the plot in interests of time. So hopefully, again, you're familiar with looking at these sorts of forest plots. We've got a vertical line at 1 where of no difference, and estimates on this side suggest lamotrigine is worse, and estimates on this side suggest that lamotrigine is better. And by and large, we're finding that lamotrigine is better than all other treatments. Of course, the estimate here suggesting overall there might be no difference between levetiracetam and lamotrigine. Most of them are statistically significant, but not all of them. When we come to look at seizure outcomes, we see smaller differences. And again, it's important to highlight here that these analyses are all intention to treat. So, and we don't have the data to allow us to do per protocol analyses. So a little bit like the SANAD trials, we're finding differences in tolerability may in fact outweigh differences in seizure outcomes. And of course, one of the challenges here is that these are quite heterogeneous trials. They're trials that are many undertaken for licensing purposes, as well as those funded by public bodies. So we've got a heterogeneous group of trials. So we might think, well, we've got some conflict here between SANAD results and a meta-analysis, but that shouldn't really surprise us given the heterogeneity. But we need to make a judgment about what we should start as a first-line treatment. I think it's very clear that we should start lamotrigine as a first-line treatment. I think that the question remains as to whether levetiracetam remains a valid first-line treatment. My instinct is no, but you may have a different view. Okay, so I'm going to move on to newly diagnosed, generalized, and unclassified epilepsy. I'm just going to check the time. I think we're okay, aren't we? Yes. So newly diagnosed, generalized epilepsy, and in brackets, unclassified epilepsy. So again, I'm going to go back to the SANAD trials, the first generation of the SANAD trials, and back in the mid-90s, and probably still now, valproate was being used as a first-line treatment for generalized epilepsy and unclassified epilepsy. And the judgment we made at the time was that we would run a randomized controlled trial, recruiting either people with an idiopathic generalized epilepsy or people with an unclassified epilepsy. I don't think we should do that again, having done the second generation of SANAD trials. And you might have some thoughts or comments on that. So this time the color scheme is similar, although we've got this orangey yellow color for valproate, and the data here are for time to treatment failure. Valproate much less likely to fail than the other treatments because it controls seizures better than topiramate and lamotrigine, and it causes fewer side effects than topiramate. So it was very, very clear, and probably what reflects very much what we see in clinical practice. Valproate, best treatment for generalized epilepsies and probably for unclassified epilepsies. And when we looked at time to achieve a 12-month remission, again, this is an intention to treat analysis, but we see valproate ahead of the other two treatments. So when we come to the SANAD-2 trial, we're highly interested in the difference between valproate and levetiracetam. And of course, this is a time when we're learning more and more about the teratogenicity of valproate, and we really need a good treatment for women of childbearing age with idiopathic generalized epilepsy. So the data here are for the intention to treat analysis, and if we just look at immediate remission, so this is achieving a 12-month remission, we see immediately there's a 10% difference. So almost 10% fewer patients will achieve a remission from seizures immediately if they're started on levetiracetam compared to sodium valproate. And as time goes on, the graphs merge over time. And again, this is intention to treat. We shouldn't be surprised by that because in clinical practice, if the treatments are failing, we're going to change the dose and we're going to change the drug. So if we do statistical comparisons, there's statistical difference here at the beginning of the curves and no statistical difference here later on. If we look at the per protocol analysis and look at the proportion of people that are achieving a remission on the drug that they were randomized to, here we see a big difference, a really big difference in the proportion of people that will achieve a remission from their seizures on valproate compared to levetiracetam, again reflecting very much what we're seeing in clinical practice. And we can also undertake some subgroup analyses. So we had enough data here to split our patient group into three. And the data here I'm showing you are for the intention to treat analysis, which is and the results are even more stark for the per protocol analysis. So we were able to identify three groups that we could do subgroup analyses in. Firstly was our group of patients with absence seizures. So this was childhood and juvenile absence epilepsy. The next group is our what we've called other generalized epilepsy. So this is patients with generalized tonic-clonic seizures with or without other generalized seizure types. And then our third group is patients with unclassified epilepsy. So the first thing to focus on, I think, is the other generalized epilepsy group. And I think what's very clear is the group of patients that are most disadvantaged by starting levetiracetam is this group of patients that are mainly those with tonic-clonic seizures. And I think this is a real worry because quite often people with generalized tonic-clonic seizures have infrequent seizures. So it's going to take us a long time to be confident that levetiracetam is failing before we switch to another treatment. So I think that our patients with tonic-clonic seizures, generalized tonic-clonic seizures, are the ones that I worry about most if we're going to start levetiracetam rather than sodium valproate as a first-line treatment. We don't see such a big impact for absent seizures, and I think pediatricians are initially first surprised when they first see this, because again our experience is that levetiracetam is not as good a treatment as sodium valproate. But of course, absent seizures occur very frequently, so we're going to find out very quickly that levetiracetam is failing and switch it to sodium valproate. So from a policy point of view, there's probably little to lose from starting levetiracetam if that's the drug that we need to start. For our unclassified patients, there's a clue that we don't see a big difference here. And if we look at time to treatment failure, again, we can look at this in two ways. One for adverse events, and interestingly, the story is very different here than for the focal epilepsy part. We see that valproate and levetiracetam are very similar. And again, that highlights, I think, that levetiracetam causes more side effects than we had actually previously anticipated. It's a very similar adverse event rate to sodium valproate in the SANAD trials. When we look at seizure, when we look at treatment failure for inadequate seizure control, we see a big difference between the two treatments. And if we again then look at the types of side effects, we see more in the way of psychiatric side effects again from levetiracetam compared to the more common side effects that we expect with sodium valproate. So I think we have underestimated the psychological impacts of levetiracetam, and I know some of my patients have referred to keprage, the sort of the agitation, the anger that levetiracetam has triggered. And if we start to think about cost effectiveness, we see a similar but less stark picture here. And again, of course, this is something that's based on UK data and might not translate so well to India, but we see that there's a very low probability that levetiracetam is a cost-effective treatment if we wanted to use it in the NHS. So bottom line here is that levetiracetam is neither clinically nor cost-effective for newly diagnosed, generalized or unclassified epilepsy. Levetiracetam didn't meet our definition for non-inferiority, and subgroup analyses do raise concerns about our other generalized group. So really, we don't have good evidence for using levetiracetam as a first-line treatment based purely on these data. But of course, life's not as simple as that, because we have a real concern about teratogenicity. So we've got this benefit-harm to weigh, and we can't really examine teratogenicity in randomized controlled trials. That those data are going to come from pregnancy registers and from other observational studies. So we need a way of balancing benefit from randomized controlled trials and harm data that will come from both randomized controlled trials and observational data. And I think we're still on a journey to work out how to do that. And of course, our regulators are taking a view about that and making statements about what we should be doing in clinical practice. And more recently, we have some concerns about men, which we're wrestling with in the UK, certainly, and I'd be very interested to hear how you're approaching this in India. We have concerns about male fertility. What we do have is animal data telling us about testicular toxicity and some very weak human evidence telling us that male fertility might be reduced. So we're in a position in the UK where we need to tell men about these issues before we start sodium valproate. And we also have a process where men now have to sign off a risk acknowledgement form before we start sodium valproate. There's also in the background concern about a genetic problem. So there's concern that valproate has a genetic mechanism. It's a histone deacetylase inhibitor. And that might be how it causes teratogenicity and learning problems in children. And the concern is that if sperm are affected, then that might be a mechanism for children of men having teratogenic problems, but it also raises the possibility of a transgenic problem. And the animal data suggests that if mice are exposed to sodium valproate in utero, they develop autistic traits, and their children, their offspring, will also have autistic traits, even if they're not exposed to sodium valproate. So is there a risk that we've missed epigenetic effects, which are actually causing a transgenerational valproate problem? And clearly, we really need to do the research urgently to answer those questions. But so this is a very hot regulatory area in the UK at the moment, and I'm right in the middle of that in lots of ways. And again, happy to talk to you about that. So I think this is my last slide. Bottom line, focal epilepsy, lamotrigine's clear first-line treatment. I think it's debatable as to whether levetiracetam should be used as a first-line treatment. Generalized epilepsy is the benefit risk is more difficult, but in general, valproate's more effective treatment. And I think we have to have a real difficult conversation with women, and increasingly a more difficult conversation with men. And the last thing I would say is that the elderly and children are not represented in these trials or in trials in general. And it's really important that we generate the evidence to inform our management across the life course. Okay, thank you very much for your attention, and I hope that was useful.
Thank you, Professor Marson, for a very excellent talk and summarizing all the current evidence and really helping us making an informed decisions. So we'll have some 15-20 minute discussion, particularly clarifying some of the aspects, as well as we have some Indian experts to discuss about the practices in India. So let us, from the lectures, what was the first our concern was that when to start treatment. And obviously this risk stratification, that patient with higher risk group or higher seizure recurrence group, they are maybe we can start the treatment even after the first seizure. So practically putting, if the patient has first seizure, definite first seizure, and both EEG and MRI are abnormal, or patient has a focal deficit, I think that will classify as a higher risk group. So the patient, when it comes to the clinician, they want to make a decision based upon the first seizure and EEG and MRI. So would you agree to that, if both are abnormal, it may be a very simple statement, but I think clinician wants some of the simple answers for that.
Yeah, so how we tend to approach that is we tell patients they're in a high risk group, and medication might reduce their risk. Would they like to start treatment, or would they like to wait until they've had another seizure? And my experience is that goes about 50-50. Some patients choose to start treatment, and some patients prefer to wait until they've had another seizure.
But the situation in India is different. So when you put this data and this, and invariably the patient will come that, doctor, what do you suggest and what is your opinion? So invariably, then they will ask us to choose. So that is basically the, I think, cultural and socio-economic differences. So we can take the opinion of Gagan sir and Dr. Jayanti. Sir, what in your practice, this first seizure, especially in Indian context, because these patients' perceptions are different, isn't it? So,
yeah, it's always a difficult question, and um, the advantage that we have as neurologists is that we, even if it's a first seizure, we often investigate these patients, and when the investigations actually suggest, for instance, if the EEG is abnormal, if the imaging is abnormal, we think that there is a symptomatic, there is an underlying etiology. We eventually probably end up, I know that the patients often like to put the ball in the doctor's court, the neurologist's court, but still, I think so. You need to have a frank discussion with the patient and the family. Would you like to? What's your? If you have a recurrence, is that okay? Is that acceptable? Many of them would eventually say yes. No, it's not acceptable. But then there are some patients who would say, okay, fine. No, I mean, there are some patients who would say, no, I really don't want to start treatment. It's just as how much we end up explaining to the patient and how much we empower them in order to make that decision. So that's extremely important. I know there are a set of patients who would just shy away from that, I mean, it's, but the key thing is to empower them with the information and the capability to make a decision, an informed decision. And that's the key, I think so.
Dr. Jayanti, your take on that? Do you want to add anything?
No, largely I agree with what Gagan has said. I think we start a conversation and we try to gauge whether the person wants to engage in the ambiguities of decision making or would like something simplistic and a solution to their problem rather than a discussion. And based on that, we make a decision for the patient. If they are willing to engage in the ambiguity, we let them make the decision for themselves. So it is about spending a lot of time, especially I find the people who come with the first or the second seizure are the ones who take the maximum time to explain, because once it's established and they've had 3 or 4 seizures, I think the ambiguity is less evident. So yeah, I mean, that's where the art of medical practice, I think, comes in. While you have the numbers in front of you, how it pans out for each patient seems to be a little different.
So, but the thing is that, madam, if you see the practice across India and
can I add some few simple things, as you said, Chaturbhuj? It's about the MRI or the EEG, either of them being abnormal. You want to know how long it is since they have had their last seizure. And thirdly, what is their profession, what they do, and how that's going to impact them in terms of their day-to-day functioning. I think these are some questions one takes into consideration. Because if it's only been one nocturnal seizure and it's been 3 months since they had it, we don't insist on them having another, starting the medication right away. But if not, we are more emphatic about telling them if the EEG is clearly abnormal, or as you said, there is a lesion, the old scar, you may insist, and they, drive to work or things like that. Then you want to insist that they start their medications.
Yes. So the thing is, the practice in India, if you see the overall practice, and I think you have been practicing for more than 20 years, Gagan sir also. Invariably, a patient comes to a neurologist or even a physician, patient come to the neurologist later. Invariably, after the first seizure, and sometimes even if it is not seizure, patient is started on anti-epileptic drugs. That is the usual thing which we all come across. So after the first seizure, majority of the neurologists will start the treatment, irrespective of what is the underlying etiology and this. So message from this probably talk is that, and what Professor Marson has also mentioned, that a benefit is low when we start the treatment, and it doesn't change the long-term prognosis. So I think that is the one message we all of us are afraid of, that we may lose the patient. This is the usual scenario in India.
I worry about injuries. I really worry about the injuries that the patient may have. Sometimes you've had people coming with their shoulder dislocated, even after the first seizure. So that's what, makes you want to ask them to take medication.
Yeah, so those are the factors, but invariably, irrespective of many patients start, and that may be the practice which probably we need to relook into in the Indian context. That is what a more broader point I wanted to make.
I would like to add something about the Indian context. So the Indian context, just the four of us talking over here is probably the tip of the iceberg of our patients, as far as our patients are concerned. And all of us probably just need to step a few kilometers out of our big city hospitals. And this is just not a question, because you have patients who have seizures, not 1, 2, but for years, and who are not on any treatment. So I think that is a far greater problem for us, rather than wondering, what do we do when the patient, I mean, very fortunate is that patient who actually, reaches a doctor or has access to a doctor and care. So that's a very small minority, I would say. I think the choice of the drug, we should go quickly to that. And probably that would be a wider discussion, more relevant to what all of us would like.
In context, what we need to discuss, the treatment gap and those things. What we are discussing is that when the patient comes to you in clinic. So now coming to maybe the second aspect of choosing the medicine, and it is clearly established that lamotrigine is the first line drug which has been shown to be superior. But then here the Indian practice is also quite different. I think lamotrigine is the least likely to be used as a first monotherapy in India. And probably the major reason is, one is that you have to titrate slowly. So many neurologists are a bit worried about maybe the seizure recurrence during the period. And then second is that neurologists are probably more over concerned with the allergic reaction and this. So Professor Marson, what will be your take on this slow titration after the first seizure, after when you want to start the therapy, as well as the fear of allergic reaction?
Yes. So two things. One is allergic reaction rates are low, and if I can't remember the last time I saw somebody with allergic reaction to lamotrigine, but if we the titration is basically an additional 2 weeks on top of the treatment, so it doesn't really make a big difference. And when we analyzed the SANAD-1 and the SANAD-2 data, we looked at time to first seizure, and you don't see a difference. That I think that concern is largely unwarranted. And I think that's the question. Actually, the titration is just an extra couple of weeks. So so I remember. So the other thing I was going to say is that most people have a low seizure rate. So most people with newly diagnosed epilepsy, most people that you'd want to start on treatment, that they may have had 2 or 3 seizures in the past few months, but many of them will have had only 1 or 2 seizures over a longer period of time.
Okay, so yes, sir, and Dr. Jayanti, your take on this lamotrigine in Indian perspective?
Yeah, so I also wanted to point out that often we are handling patients who come to the ER with a seizure, and then you have to initiate treatment for someone like that. So in that context, Professor Marson, what would be your approach? Because, working in hospitals, this is one cohort that we deal with, that they come to the ER, they've had, a seizure, and we need to take care of recurrences and make sure they don't have another one. And how do you do any bridging if you choose to use lamotrigine? How do you handle that?
Yeah, so one of the worrying trends that I'm seeing is that patients being loaded with intravenous levetiracetam having presented with a single seizure, and that is happening in some places, and I think that's completely unnecessary. We will, I mean, if somebody's had just a single seizure, then I think it's entirely reasonable for most of them to be started on lamotrigine. Sometimes we will add clobazam as a short-term treatment whilst we're starting the lamotrigine, but I've not done that for a few years. So whilst in theory we can do that, I don't think it's necessary for most people.
Okay.
I'd like to ask Professor Peterson one question, please. In SANET 2, you did not take carbamazepine into account. In SANET 1, of course, you found carbamazepine to be as effective as lamotrigine, although I think lamotrigine was tolerated a bit better.
Yeah.
But we do not really have clarity as to what doses were used and what formulations were used. Because I think we use a lot of carbamazepine, and our patients in focal epilepsy, they by and large do well,
Yep.
So I'm interested in knowing why it was discarded and not kind of, why didn't it enter SANET 2?
It was a pragmatic decision based on cost and timeliness. So if we would have included carbamazepine, we considered including carbamazepine and also lacosamide in the trial. But if we had for every drug we included, we had to recruit another few hundred patients, which increased the cost. And also it would have meant that it would have taken another few years to get the results. So the very first time we contacted our funder to say that we would like to do this trial, we actually put in a trial with more treatment arms, and they said, no, this is too expensive, it's going to take too long, we want an answer sooner, do something smaller. So that's what we did.
And it's the cheapest drug for us. It's way cheaper than lamotrigine.
Yeah.
And it may well be that it's entirely reasonable to be using carbamazepine as a first-line treatment in most situations in India. Absolutely, it's a very effective drug, and 15 years ago I was prescribing it all the time. Now I prescribe it probably about twice a year.
Okay.
But in your practice, do you feel that carbamazepine is efficacy-wise, not the scientific, is better than other drugs, including lamotrigine, or in a clinical practice?
Yeah, I don't know.
Yeah.
Carbamazepine might have the edge over lamotrigine in terms of seizure control, but it causes more in the way of adverse effects, and interferes with contraception and the other challenges that we.
Yeah, but lamotrigine, as far as contraception goes, I think equally challenging.
Yes,
for other things, yes, bone health and so many other things, yes. Yeah.
So the thing is that in India, we use lamotrigine, I think, very infrequently or almost non-existent use, at least in the first line monotherapy. And invariably, majority of patients are actually who come to the clinic are started on levetiracetam rather than the lamotrigine, which probably has been now because once it's believed that it is better, safer, but the trials have shown that actually lamotrigine is more efficacious and safer as compared to levetiracetam. Yeah. So I think that is the one message probably to the Indian neurologists, that probably we need to use lamotrigine more.
Or use less.
No, I don't think we need to. I don't think we need to beat ourselves up because we are not using a lot of lamotrigine. We are fine using carbamazepine. Yeah,
I agree.
Yeah, but
Jagan has something to say. Yeah.
I think. I mean, I feel about lamotrigine, as far as I'm concerned, I actually, on the contrary, use it quite a lot. Because I think, one, if it is titrated, what people have a problem with lamotrigine is with titration. And then this belief that it is going to cause allergic reactions. If you titrate it slowly, I mean, there are no adverse reactions. There are no allergic reactions to. And clearly, as Tony also pointed out, that this is a population where the risk of seizures is not that high. I mean, it's not that they're going to have immediate seizures. There are situations, for instance, someone has a brain tumor, someone has a cysticercus granuloma. They're at risk of immediate seizures. So that's probably a situation where we should not use lamotrigine. But rest of the situations, I think lamotrigine should be a drug which should be used more often. I completely agree that in our hospitals, what happens is that patients often land up in the emergency services, and there the resident has already administered a loading dose of levetiracetam, and then you think, okay, fine. Now this guy is already on levetiracetam. Now why do I want to change the medicine? Let's continue and plow on with levetiracetam. In case it doesn't work, there are side effects, or there are issues with efficacy, then we go on to a second drug. So that's the practical situation that happens often. But overall, I think people are more scared about lamotrigine, and which they perhaps should not be, because I think it's a fairly simple drug, and just like levetiracetam, but of course, I do agree that people are a little scared about it, and the idea is that it's a good drug, and it needs to be. There are some situations where it works very well, and it should probably be used. We should not worry about not using it. But your point about carbamazepine, I mean, the good thing about carbamazepine is the cost. And I think it is slightly more efficacious than lamotrigine, at least in focal epilepsies. But the issue about long-term and this long-term side effects is also another, if I may say, a Pandora's box. And there is more and more evidence of long-term adverse effects of the inducing drugs. But you have to kind of balance it. It's cost versus so many other things.
I agree.
So coming to the generalized epilepsy now, because valproate we know that it is probably the most efficacious drug. There is no doubt about that. But now we have been not using in the women, but now it is a concern in even using in the men also, with this new side effects coming. So that is a real issue because some of the patients we can be controlled only with the valproate and nothing else. So how do you address all of us this issue of choosing the therapy? Because now trials have shown that valproate is the most effective, but even in the male now, have you started switching to the other medicine other than valproate?
And which one would you use then?
So our practice is changing in the UK, certainly. So for a long time, as I'm sure you have, we've been avoiding valproate as a first-line treatment in women of childbearing age. Excuse me. And that is difficult, isn't it? And I still see young women that I'm sure have come to harm because there's been a real reluctance to start sodium valproate. So burns, depression, injuries. It's it's really difficult to get it right. But of course, these are individuals that aren't thinking of starting a family anytime soon. These are young women that are having their education and employment prospects, damaged by the fact that their epilepsy isn't under control. So it's a really difficult balance to get right. And it's really difficult that, when do you start valproate in a young woman? How many treatments does she have to fail if she's got juvenile myoclonic epilepsy before you go to sodium valproate? So in my consultations, for the newly diagnosed, we'll discuss the fact that we've got this drug valproate, most effective, but we should think about these other options because of policy and risk. But as soon as the first drug's failed, valproate is on the table as an option for women with juvenile myoclonic epilepsy, and that, there's a real autonomy issue here. Why should women be denied the most effective treatment for their condition? And so I think we need to be very careful. And some women will choose valproate, and some will say, I don't want valproate, and that we need to have them in the conversation. And as you say, for men, it used to be very easy because we would just start all men on sodium valproate with Jamie because it's straightforward. We've now started to have the conversation. The way I approach it in the clinic is to have a conversation with men, pros and cons. What do you want? And I've had conversations which have gone either way. I think more men have chosen sodium valproate than have chosen to go for an alternative. And I think that's still a reasonable approach given our current regulations. But we're also going through a process in the UK of having to what we call double sign. So all of our cases on sodium valproate, all of the patients have to sign a risk acknowledgement form, which has to be signed by a neurologist. We've got to go through a process whereby every single patient on sodium valproate is assessed by two, or has the form signed by two consultants. So we're going through that at the moment, and there's a real risk here that a lot of resources are directed towards having double sign-off, which means that some patients aren't getting appointments, or because we're so focused on the sodium valproate issue. Sorry, that was a very long-winded answer to your question. I hope that gives you a flavour of what we're doing in the UK.
Yes, I think we got it. Dr. Jayanti has some comment, or anyone?
No, I wanted to ask you, Professor Marsden, how strong is the evidence for risk for men? And is the evidence strong enough for you to use it and kind of discuss it at length and even avoid using it? Or is it yet very, very early evidence? Do you still discuss it if it's not sure, or do we have, in other words, what is the kind of evidence we have? And how do you put it across to the patient?
So the evidence is weak, and we have animal data that are for reduce smaller testicles in animals, test smaller testes, and evidence that there are fewer sperm, problems with their motility, and problems with their morphology. What we don't have is any evidence that tells us whether men are less fertile. So we're making an assumption that those changes in the sperm are reducing fertility. And of course, we've all got men in our clinics on sodium valproate that have fathered children, so clearly not making them infertile. The evidence for possible kind of learning problems comes from analysis of a Scandinavian database, which has been reviewed by the regulators, and that needs some more analysis. So it's observational data, which gives a signal. So the evidence is really weak, and of course that makes it really difficult because we can't speak about specifics in the clinic. In the UK, the form that the regulators have produced that men have to sign has statements about the possibility of reduced fertility. So we can't not have a conversation. We have to have a conversation with men. So I explain that there's a signal that there might be a problem. We're not sure whether it really is a problem, but the problems that there might be are that it might reduce your fertility. That's the main thing that we're worried about. And I also say that for a long time we've been worried about children born to women
Yes.
taken to men.
Autism would be more worrisome.
And the question's been raised as to whether that might also be a case for men, and we don't know. But we're telling you this now because the concern's been raised. And of course, it's really frustrating to have a conversation about possibilities and maybes. It's really difficult.
So just
Has
one
that-
question.
Sorry.
If you're really in a corner and sodium valproate, has to be used, what about the dose? That one could be a little less kind of, worried with. Is there any such consideration here, both for men and women?
So there's no safe dose. For women, a dose of 800 milligrams a day or less might be better. For men, I don't think we know. We haven't got the data. I don't think we've got any good data about dose effects in men and fertility.
Okay.
Okay, so maybe last two questions. What is because it has not been tested in SANA trials, but both lacosamide and perampanel. So how do you use in your practice both this medicine? Future, do you see lacosamide becoming a good drug for the focal epilepsy, and whether this will be a SANAT 3 trial for these medicines?
Yeah. So,
It was about to ask that.
yeah. So I'll probably be about 70 years old by the time SANAD 3 has been done. So that might be something for my younger colleagues to take on with my support. But seriously, so lacosamide. So I don't think there's any reason to be using lacosamide as a first-line treatment. We've already got carbamazepine and lamotrigine and other treatments, but it's probably an effective drug for focal epilepsy. I tend to use it for patients where we've had a problem with lamotrigine or carbamazepine, and then use it as a sodium channel drug in focal epilepsy. I haven't prescribed a lot of lacosamide over the years because if we're adding lacosamide to carbamazepine or lamotrigine, then we're probably going to cause more sodium channel side effects. And of course, that's theoretical, but we've not prescribed traditionally a lot of lacosamide. I've also prescribed lacosamide for patients with refractory generalized epilepsy, particularly if they're having generalized tonic-clonic seizures, obviously based on pretty limited evidence. Perampanel is, in my experience, a drug which is associated with quite a lot of side effects and toxicity. So we've prescribed quite a lot of it in the first instance, but we've not really prescribed very much of it in Liverpool over the past few years. We're starting to try it again in patients with refractory generalized epilepsy because there are anecdotal reports that it might help with generalized tonic-clonic seizures. I'm aware of that anecdotal evidence, but I don't have good experience of it at the moment as a treatment in idiopathic generalized epilepsy.
Chadboj, I just have one last question, please.
Yes,
so
yes.
although this was just about the first drug, but I am curious to know about how often you use clobazam.
A lot.
A lot. That's what I thought. It's such a fabulous drug.
Yeah, it's a great drug. So we use clobazam as a treatment in refractory epilepsy, mainly refractory focal epilepsy, but also in refractory generalized epilepsy if there are generalized tonic-clonic seizures. So my go-to drugs, if lamotrigine isn't controlling, my go-to second-line drugs are levetiracetam and clobazam.
Clobazam,
So it's really cheap, isn't it? And I think there's this kind of theoretical concern that there's tachyphylaxis, that the effect wears off. Not true. It's not true. It doesn't happen. So it's theoretical. It doesn't happen. And there are also concerns that there are benzodiazepine withdrawal effects. There aren't. It's a really safe and cheap drug and really effective.
Yeah. Thank you.
So before I invite Dr. Mamta for the vote of thanks, one request that when we can approach you for the talk when the first monotherapy fails, what to do next. So probably sometime in the future, medical management of when the first monotherapy fails, as well as the drug refractory epilepsy. So probably we might approach you. Thank you very much, sir. And I invite Dr. Yes.
I'll just say to that. So I'd be very delighted to join you again. We've got a teaching session at the European Epilepsy meeting. And I think we'll probably put a proposal in for the international meeting as well, which kind of addresses that. There's me, Jackie French, Torben Thompson talking around some of those issues, and I think you've got Torbjörn coming to speak to you at a later time point, haven't you? So yeah, and it's very easy on Zoom now, isn't it? It's much less disruptive.
Yeah.
So that will be really wonderful, and I think I will definitely be in touch in the next. I invite Dr. Mamta, our chairperson, to propose a vote of thanks to Professor Marson.
Thanks, Chatarbhuj. So of course we'll hear Professor Marson about when the first drug fails, but till we hear him, I think we could all go away with the message that if the first drug fails, just add clobazam first, and you may have found your answer. But anyway, it's been a wonderful evening. Thank you so much for sparing your time, and I think all our viewers must have really benefited from this, and we look forward to hosting you again. Hosting you is slightly grander. Zooming you again. Good night, everyone.
We definitely would like to you sometime invite to India and probably for the talk as in-person talk. So both Professor Gagandeep Singh is in the managing committee of Indian Academy, and I think sir will definitely look into it.
I'd be delighted.
Thank you, Gagandeep sir and Jayanti madam.
Thank you so much. It was very interesting.
It was a lovely talk and
lovely talk. Yeah.
Thanks very much for your time.
Thank you, sir. Thank you for joining. Thank you.
Right. Well, how do I leave?